when we talk about imparting it through us or through partners, what can be a more bigger mecca of ophthalmic surgical training other than Arvind Eye Hospital in India, in Madurai? So may I now please invite Dr. Shankarananthan or Ravilla to speak about his initial experience with simulation-based training in a tertiary eye care center at Madurai. Dr. Shankar, over to you.
Thanks, Dr. Akshay, for this opportunity and help me see also for this opportunity and recognizing Aravind as one of the centers in your. So I have no financial interest to declare, and so just to set the context, I'm just sharing the details of the performance of Aravind Madurai alone in terms of surgical volume. So why is this number important? This 1.9 lakhs that we have done last year. Why is it important? Is you can see now most of these surgeries, or at least 70% or close to 65% at least, have been done by junior medical officers and doctors who have very minimal exposure. So this is the main reason why we tend to take training very serious. So account the total number is 78,000 that were performed by juniors, and our seniors had conducted a study in which they have found out that it requires at least a number of 300, close to 300 SICS surgeries to have their junior surgeons bring their complication below 2%. So 300 SICS surgeries, it's quite a lot of number. So we need some kind of a training module which can bring it less than 300. So that was the main goal. And so the other thing is, like in an SICS in general, we should understand that how much ever you train a surgeon in whatever subspecialties they do, cataract surgery unfortunately is still the bread and butter for most of the surgeons outside. So you need to master this well to make even your basic income, if because outside that is the scenario. So in SACS, if you can just learn the basic steps to perfection, it will reduce almost most of your intraoperative complications in whatever challenging situation that the surgeons may handle. And this will always reduce the learning curve also, and the residents will love to do surgeries. Though that is the main reason why we need to train them better initially. And so these are the what even though simulator is new and new to the scenario in training, we can't forget the uh, previous, I mean, we can't forget the history which has brought us to this stage, like IOC sir have all been trained in cadaver eyes and rexus boxes. So what did the traditional wet lab training lack, and what does simulator brought up as an advantages? Like if you consider a person training in a gym, a person training in a gym can always go and work out and come. But when you have a personal trainer standing nearby, he'll be the person to dictate, to tell you exactly how to do it, what muscle, what exercise needs to be done. So a simulator gives you that advantage. In cadaver eye or in rexus practice in a polyethylene film, we will never know in what angle the trainee practices in what depth he is in. But uh, when it when it comes to the simulator, that's the biggest advantage. And so the disadvantage in the old methods were, especially during the pandemic period, we didn't have the chance to give any of our surgeons, junior surgeons who are still in the institution with us, a chance to perform live surgery. Had we had the simulator at that time, at least they would have practiced it m number of time. So putting it into context, now we got the simulator with the help of our management in 2021 and 26th March, and that's me here practicing with our getting introduced to the simulator in the Mumbai center, and still far we have trained 168 surgeons. So now we categorize our surgeon trainees into 4 categories. So the first one being the fresh graduates who have literally no experience with MSICS. So this group trains with us for 1 month. So every month there are a set of residents and fellows who get trained in SICS with the help of the simulator. And the second, third, and fourth are groups which have approached us literally seeing the benefit of the simulator helping the junior surgeons. There have been surgeons who wanted to quit surgeries, but now seeing how the residents are doing well, they have approached us on their own, And actually, this group was not there before. Even Ashish would agree, is an old alumni of our institution. So they created this group. Like they came to us and they requested, "Sir, I am having too many complications." So that's the group. The second, they have done lot number of surgeries, but still their complication rate is high. So we brought them. We worked up with them for 45 days. We constantly monitored them. And then the third is much more interesting. Like we have fellows who are doing 30, 40 per ton, but they want to do higher volumes. So they feel, because like I told you, another important thing, like I told you, was like post COVID, we have increase in number of fellows, but you don't see an increase in number of patients on a single day. So what do we give them? So we can give them only 2 tons, maximum 3 tons a week. So we need to accommodate all the surgeons also in the 6 day period. So every turn they would like to do a high volume. So for that they need to be trained well, they need to be confident, and they have to also have their complications less. So this was always achievable by the simulator, because they can practice empty number of times. Yeah, tunnel they can do 100 times, the rexes they can do 100 times. So whatever it is they can do, how many, and in particular is high volume, they may have some lacuna in particular step, that alone they can practice. Because in the and another thing that I failed to mention was, in the cadaver eye you can't do anything other than the rexes and the tunnel, but when it comes to the simulator you can do A to Z entirety. And the last is with the complication management system that they have brought up. The group 4 surgeons, now they are high volume, but they want to do manage complications. So it helps us reach to the stage like much earlier. For example, we have few of my fellows who are sitting in the audience also. They were initially to come to the stage pre-COVID. The fellows, they used to take around 2,000 cases, but now we have fellows who have done only 900 cases, close to 1,000, but they're able to manage others' complication and their own complications. So this gives a big advantage for the simulator. So this is an this, if you see, these are medical officers who are trained, PGs who are trained with us. They have the numbers, but see, their complication is quite high, resurgeries are quite high. And once they trained in the simulator for a month, this is the jump. And this in between, she went on a leave long term, so she hasn't come back yet. But look at this number, 2,290. Previously it was 726. So this is big jump from 239 to 876. It's a very big jump. So these numbers are not only these are not going to be seen by your colleagues on a day-to-day basis, but they see your confidence, they see your face after your surgery. They that brings them the confidence, and they come to us, they approach us on their own, and they train with us. So as Ashish told us, the suturing module, phacoemulsification and trabeculotomy are down the pipeline. It's going to come, and this is going to increase our workload a lot. They may just give the mission, but it is going to pressurize more. So advantages, like I said, you don't need a cadaver eye. You can practice how much ever time you want. And the most important thing is, like in the previous first presentation, it was mentioned that the trainers have a lot of other things also to be carried on as their role. So you don't need someone to stand next to you. The machine literally spoon feeds you. It's like holding your hands and doing stuff. And next is the remote training. Like we were very fortunate to have one of our one resident to be trained by remote training from Mumbai. He's doing extremely well now. So it doesn't mean like you need to have anyone standing next to you. You don't have to be in the same room, in the same floor. You can be anywhere, and you can still monitor what your trainee does. And the ebook, like Dr. Ashish said, it's an A to Z. The first time when I saw this book, there were lots of questions as a trainee, as a trainer, and as a senior consultant. This book answers all those doubts from A to Z. Rather than teaching, it also answers the questions also. So it's a very good. It's an online ebook, so you can always have access to it. So when you give a job to your colleague or anyone, there must be something for them also in it. You can't just give it to them, because it won't be a continuous cycle. So as a trainer, they become more aware, they become confident, their complications come down, and they're more consistent also. So when they teach, they hear what they say, and they become more and more confident. It makes the trainer become want to learn more about a new cataract surgical procedure, challenge himself so that he can be able to train much more people. So like I said, training is not something that's going to stop today or tomorrow, or it's a continuous process, both for the trainer and as well as the trainee. So with this, I feel, and in Aravind Madurai we are offering a 1 week course and a 10-day course which involves only the simulator, and in case you need to use the live surgery part, then you need to enroll for a 1 month period. Okay. Thank you.
Thank you, Dr. Shankar. That was great actually to gain more insights about how the training has affected with the introduction of simulation-based training at Arvind. We could see the numbers of those particular trainees go up, and I'm sure when there is one instructor less looking at these trainees, the volumes also go up for the other surgeries in Arvind. So that was very nicely presented. Thank you.